Okay, introduction to protocols, patient care, part 2. Helical spiral CT. In helical or spiral technology, the table moves continuously during rotation of the gantry, carrying the X-ray source and the detector arrays. The technique does not lead to the acquisition of a collection of axial slice images, which may, if required, be assembled to obtain a volume dataset, but rather to the primary acquisition of a volume dataset from the outset, from which, if required, not only axial, but any other planar slice reconstructions may be made or other image analysis carried out. And so basically what this is saying, this big long paragraph, is saying that we now have the ability to not only acquire images in the axial plane, but we acquire them in a plane and combine them so that we can recon anything that we want to. We can do obliques, we can do coronal sagittals, we can do volume rendering, VIP, things like that. In the case of a single slice spiral machine, the pitch is said to be 1:1, which means that you want collimation, which is equal to the beam width, to the same as the amount as the table moves. Greater pitch obviously reduces the image acquisition time for any physical length of scan, and also reduces the amount of radiation absorbed by the patient. And so for those of you who are in physics, this should make a little more sense, but for those of you who aren't in physics, it's very simple. Pitch is a relationship with collimation and how much the table moves. And so when you have a 1:1 ratio, it means that you are coming up with a pitch of 1, which means that your table is moving the same amount that you're exposing the patient. If you have a pitch to be 4, 5, 6, it means that your table is moving more than what the collimation actually is, or you're not exposing the patient as much. And so your patient dosage goes down, but your image quality also goes down. The pitch, if you have a small pitch, like you have a 0.5 pitch, then that means that you are overexposing the patient. It means that the table is not moving as much as what you're exposing. So you don't want that either. And so, as we see here, greater pitch means that you can acquire the images faster because the table is moving more, and that you don't give the patient as much dosage. So that should make a little bit of sense. However, a greater pitch also causes a decrease in the image quality and decreases spatial resolution. For those of you who are in physics, spatial resolution should come up on this lecture as well. And we define spatial resolution as the ability to image very small things. Could be small things such as stranding in the mesentery due to an inflammation, a fluid level, a rupture, a small amount of air somewhere, or a very small nodule in the lungs. Things like this are what we need great spatial resolution for. Pitch becomes more complex in multi-slice machines, though, which we won't get into for the helical portion for protocols, because this is kind of beyond our scope. But for those of you who are in CT physics, you will understand how complex this actually has become because of multi-slice. But the thing that we really have to worry about in all of this is, if contrast is given, how can we make sure that we are catching the contrast in the proper situation, in the proper organs, in the proper vessels, and doing it adequately and at an expedient fashion? And so how can our protocols be tailored to overcome these hurdles that multi-slice CT sometimes presents because we acquire images so fast? So that's one thing that we have to worry about. So in terms of data acquisition or image acquisition, we see that multi-slice, spiral, or helical scanners may be used in a variety of modes as circumstances require. Some of these circumstances can include trauma, which allow the entire body to be imaged in a relatively short amount of time. And so we all know, we've all been in these trauma situations to where you have to get the scan performed rapidly. And once you get the scan performed rapidly, you have to get it reconned. You have to do all of these manipulative techniques to the image. And so multi-slice has really helped us out in that we can get the patient in and out of the CT suite very rapidly, get them on into something else. If the physician, the attending physician, is really concerned that something may be going on, they can actually come over to the CT suite while you're reconning and look at images that are being processed, or they can wait a few minutes for everything to be transmitted to PACS. But multi-slice CT really shines in trauma situations. And that's really because we can use 3D reconstruction and manipulation. So if there's something that you're wanting to see just a little differently, we can pretty much recon the images however you see fit. Also, we use multi-slice CT in demonstrating phases of contrast enhancement. Multi-slice CT has really come about and come into its own in multi-phase organ enhancement, such as liver studies, where you catch arterial and venous flow, CT runoffs, things like that, to where we can really see these vessels adequately. So venipuncture. The injection of a medication or contrast agent directly into the bloodstream is a type of parenteral administration. So keep that in mind. Parenteral. Sites commonly used for IV administration of radiopaque contrast agents include the anterior recess of the elbow, or the antecubital space. This is what you're going to hear it called more often, the antecubital space. The radial aspect of the wrist, the anterior surface of the forearm, and the posterior portion of the hand. Primarily for high flow rate scans, which require a larger needle, it's usually advisable to go for the antecubital space. And we have to understand that venipuncture is accomplished using the aseptic technique. So the components of aseptic technique include thorough hand washing between patients, wearing of disposable gloves, cleaning of the site of venipuncture in a circular motion with an alcohol swab, moving from the center to the outside. So you begin with the center and you move it outside. That's one of the most common mistakes in aseptic technique. People start from the outside and work in, but actually all you're doing is covering the area up with bacteria that potentially could exist. And so you take the bacteria away. I guess that would be the best analogy there. And the application of a gentle pressure with an alcohol swab to the venipuncture site after removal of the needle or catheter. And so once you pull the needle out, a lot of the times we have just a tendency to just put a 2x2 and some tape on it. But actually, we need to put gentle pressure with an alcohol swab. Even though it may burn and sting slightly, it will maintain that this area is clean for preparation to put a bandage on. So that brings us to the injection technique. We see that there are several different techniques. We have the drip infusion, in which the volume of contrast agent is administered at a slow rate over a long period of time. It's no longer typically used in CT procedures. And once you think about it, really, why would it be used? There's really nothing that a drip infusion could really benefit in terms of CT. We also have a bolus injection, in which the iodinated contrast agent is pushed into the bloodstream at a rapid rate over a short period. And that's typically what we have, a bolus injection, where you push a large amount of contrast in a very short amount of time so that you increase the blood serum levels to an adequate range so that it's detectable in terms of CT. And we can see that a bolus injection may be accomplished by hand injection or power injection. We typically think of a bolus being power injected, but you can actually accomplish this by using your hand as well, just pushing a syringe if the IV is adequate. Power injectors are capable of consistently injecting large volumes of contrast agent flow rates up to 5 to 6 milliliters per second. Factors determining flow rate is clinical area of interest, contrast volume, venous access, patient condition, and pressure capacity of the IV materials. And so So I would put a star by this so that you can see what is really affected. Typically, what are we shooting for to image, and then how much are we giving is things that we take into consideration. But mostly it is what kind of access do we actually have. Is the catheter very good, or is it kind of difficult to push? Are we not getting good blood flow? Are we sure that it's not extravasated? Things like that. Also, patient condition can really be a detriment to how much that you're actually pushing, because as we know, patients with congestive heart failure or things like that may not actually have adequate ability to push the contrast out of the right ventricle and the left ventricle, and so you may not actually get the enhancement that you're shooting for based on the time frame. And then also the pressure capacity of the IV materials. Definitely you want to be mindful of what the IV can actually hold and what its rate is tolerable at, and not exceed that. Injection technique. Injection should be performed through flexible plastic angiocatheters rather than standard metal needles. As we all know, we've gotten away from using actual metal needles being inserted inside of patients, except for butterfly needles. The metal needle was used to actually put the angiocatheter into the patient, but once the angiocatheter is in, the metal needle is actually removed. And so that works out really well for us, because we do not want to be injecting at a high flow rate, damage the metal needle, and fragments break off and go into the bloodstream. That would not be very good at all. We do see that 22 gauge angiocatheters are sufficient for flow rates up to 3 milliliters per second. So keep that in mind. You can get up to 3 milliliters per second on a 22 gauge angiocatheter, but typically you want to strive for something better, like a 20 or a larger needle such as an 18, things like that. That's what you really want to shoot for, because they allow flow rates to exceed 3 milliliters per second. Also, it'll decrease the amount of pressure that you need to exert, simply because you have a larger diameter there, and so your pressure rates will actually decrease as well. Proper bleeding of the tubing eliminates air, and the injector syringe should remain in a downward position before administration of the contrast agent. So that's something that a lot of people don't keep in mind either, that when you finish drawing up or filling your injector, put it in a downward position so that the air actually goes to the top and you actually don't inject the air into the patient's body. You do not want to have an air embolism occur, because, as we all know, pretty much fatal. There's nothing that you can really do about it, but the good news is that it requires a large amount of air that typically you will not get even if you forget to bleed the tubing. But that's something that you want to keep in mind. Just put a star beside this, that you certainly want to bleed the tubing and keep that air from being injected. So never inject without bleeding the tubing, getting contrast and saline to actually go out the end of it. So that brings us to the advantages of the power injectors. We see that they have consistent, reproducible flow rates. They deliver precise volume, and they have dosage control. They have higher injection rates for optimal contrast enhancements, because they can push faster than we typically can. Automatic delays for proper enhancement patterns and multi-phase imaging, so they take all the guesswork out and make everything adequate and accurate. The ability to administer normal saline as a flushing agent. That's one of the most important things that we do now with CT is we can deliver a slightly lower amount of contrast medium while pushing saline, which allows the contrast to actually enhance as adequate. Flushing the tubing with a volume of saline 30 to 50 milliliters immediately after the contrast agent. Bolus allows for a reduction of contrast agent dose and helps eliminate the streaking artifacts. So it allows the dosage to be less, but it provides the same quality of images. The major disadvantage of the use of a CT power injector is the increased risk of extravasation or infiltration of the contrast agent outside the bloodstream or blood vessel. And so basically, typically because you're using such a high flow rate and sometimes higher pressure, that typically you don't actually know that you have caused infiltration to occur until it's almost too late. If you're going at 3 milliliters per second and it takes you 2 seconds or 3 seconds to actually be aware that infiltration has occurred, then all of a sudden you've injected almost 12 milliliters into the patient's extracellular space. And so it becomes very difficult to discern sometimes, and so it's very important that we understand that there are risks associated with the power injectors as well as benefits. So, in using a power injector, before the injection is begun, the technologist should check venous backflow by drawing back manually on the injector and observe blood flow into the connective tubing. I want to say that this is not always the case. Sometimes you cannot get blood flow to return back. It's depending on things that are sometimes beyond our control. How much fluid has been pushed through the IV, how much has actually, or how long has the IV not been used. Things like that can also affect whether we can actually draw back fluid or not from it. So if you don't see blood coming back when you draw back, don't be alarmed. What I typically do before I hook the injector up is I take a 10 milliliter syringe of saline and I attempt to draw back on it first, and if that doesn't work, I push the saline through and see if I can feel it going through just by palpating the area around. And if I'm not seeing anything that looks like an infiltration, then typically we'll go ahead with the injection. But if there's any discrepancy there, then it's always best to double check things. Power injection must be stopped immediately if extravasation occurs. So if infiltration occurs, stop the injection immediately. I know it's going to take you a couple seconds to actually discern that something has went on, but as soon as you realize it, stop the injection. The IV administration of a contrast agent typically consists of an intravenous bolus injection through an 18 to 20, should not be 23, but a 24 gauge angiocatheter or butterfly needle. The angiocatheter is an IV catheter placed within the vein and used to administer fluids, medication, and or contrast medium. So we all know what an IV is and all of that. So I don't think there's a great discrepancy or concern there that we don't know what it is. But the real problem lies with the power injector. For all of the benefits that the power injector gives us, it does open up new problems as well. And so it's something that we have to be mindful of, that things can occur. Rarely, if the patient is properly hydrated and the IV is in an excellent spot, usually infiltration does not occur. But on the off chance that it does, it's important for us to be aware and mindful of what we can do about it. So this brings us to a butterfly needle, which I'm pretty sure that we all really know what a butterfly is. And we see that it consists of a hollow needle surrounded by plastic flaps or wings. The wings are grasped and lightly pinched together to facilitate insertion, so it gives you something to grab a hold of as you push it into the vein. One thing to keep in mind, though, is that it's a hollow needle, and so it still has the metallic properties here, which are not ideal for high flow rates and high injection pressures, which are used in power injectors. Typically, butterfly needles are used for things such as the CT of the head, in which power injector does not necessarily have to be utilized. So the range of serum iodine concentration for adequate opacification during the CT examination is 2 to 8 milligrams per milliliter of fluid injected. Common types of central venous catheters are subclavian lines, implanted access ports, and peripherally inserted central catheters, or we call them PICC lines. Flow rates for injections through central venous catheters are typically reduced to well below 2 milliliters per second. However, there are special types of catheters that have the capability to handle much higher flow rates and are adequate for power injection. The typical rule of thumb, though, is when you're dealing with central lines, PICC lines, things like this, find out as much as you can about the information regarding the catheter, and then check with the attending physician or the radiologist to see whether they even want you to utilize this, because many times exams get ordered without actual knowledge being or thoughts being given to what the patient actually has for intravenous access.
So when giving IV contrast, there are some special considerations. In general, for patients who are to undergo administration of iodinated contrast media, attention should be paid to the 4 H's. The first H is history. And history includes details regarding the patient's allergic and contrast agent history that must be reviewed. So basically, you take into account what the patient is allergic to and if they've ever had iodinated contrast before. The second H is hydration. Adequate hydration must be ensured before, during, and after the examination. One of the things that can decrease renal function is dehydration, and so it's essential that the patient be hydrated. The third H is have, and this pertains to equipment and expertise ready. A detailed plan to treat contrast agent reactions should be in place. So there has to be something, a protocol that is in place in case a patient does have an allergic reaction to the contrast medium. And the last H is heads up. Constant assessment of the patient's condition is vital for early identification and proper treatment of an adverse reaction. And so constant monitoring of the patient to see how they're progressing during the scan is essential to ward off any type of reaction. And so if you can catch the reaction very early, then you can head it off, hopefully, from becoming a very severe adverse reaction. So in terms of reactions, we see that an allergy to an iodinated contrast medium is not the only thing that will increase the risk of reaction. We do see that physiological and pathological processes sometimes will increase the risk of reaction, and these processes are asthma, environmental and or food allergies, renal disease, multiple myeloma, diabetes, sickle cell disease, pheochromocytoma, hyperthyroidism, and cardiac disease. So these are some of the things that can increase the risk of an allergic reaction, even though an iodine allergy may not be present in the patient. So contraindications to IV iodinated contrast agents include an allergy to iodine, which is very obvious, a prior severe allergic reaction to an iodinated contrast agent. So if the patient has had an allergic reaction at some point in time, then it's always good to give the physician a heads up and see what they recommend. Renal insufficiency or failure, because the last thing we want to do is actually dump something that's going to be extremely hard for the kidneys to excrete into the bloodstream, and so can lead to higher levels of toxicity. And then, interestingly enough, pregnancy is not a contraindication for iodinated contrast medium. We find that even though contrast medium is known to cross the placental barrier, pregnancy is still not a contraindication for iodinated contrast usage. However, the fact that the patient is pregnant might be a contraindication for even doing the CT scan. The regimen to reduce the risk of reaction typically consists of a combination of antihistamine, such as diphenhydramine, hydrochloride, or Benadryl, and a corticosteroid taken at timed intervals beginning as early as 24 hours before the contrast agent administration. So typically, we know that if you've had a reaction, there's a strong possibility that you will have one again. And so the best way that we can head it off is to give you something like Benadryl or some other type of antihistamine and a corticosteroid to actually head this reaction off. So nursing mothers, we saw that the iodinated contrast can cross the placental barrier. So what happens after the pregnancy is completed? We see that nursing mothers may be injected with iodinated contrast agents as clinically warranted. However, there is a stipulation here with this. Nursing mothers are typically instructed to pump and discard breast milk for 24 hours after administration of contrast agent to be effective in eliminating the risk to the infant. And so that's something to keep and be aware of, is that if you do scan a nursing mother who has just completed her pregnancy, then typically you're going to want to tell them to pump their breast milk for 24 hours and discard it, so that you decrease the risk of passing along some iodinated contrast in the milk to the infant. And that could be disastrous, because if the infant does have an iodine allergy, then there's several things that can go wrong with this. So it's essential that they do this. So that brings us to mild reactions. The majority of adverse reactions to iodinated contrast agents can be characterized as mild and non-life-threatening. That's the good thing. These mild reactions can include nausea and vomiting, mild urticaria, which are hives, a pronounced sensation of warmth and or flushing. Many times you'll get patients that say that they feel like they're getting really warm, and then it kind of goes away. And so that can almost be described as a mild reaction in itself. Altered taste, that's another thing that you have a lot of patients actually experience. A lot of patients get a metallic taste, and that is simply just a very, very mild form of reaction that's non-life threatening and will quickly go away. Also sweats and chills, nasal stuffiness or sneezing, and an anxiety. Usually these require no treatment, yet the patient should be observed until symptoms dissipate. And luckily, most of these symptoms go away as quickly as they came, and so the patient will feel it for just a few minutes, and then the sensation will be gone. So that's the great thing about mild reactions, that really they don't cause any harm to the patient or their well-being. So moderate reactions. Moderate reactions are usually non-life-threatening, but may progress rapidly. These include mild bronchospasm, moderate to severe urticaria, a vasovagal response, tachycardia from hypotension, and these are things that usually require some degree of treatment. Treatment for moderate reactions include bronchodilator inhaler, oxygen therapy, Benadryl, or elevation of legs and IV fluids for hypotension. So basically, we can counteract any of these reactions pretty simply by just providing small amounts of interventional or therapy to decrease these reactions. So Once again, moderate reactions are slightly more severe than mild, but they're something that can be remedied very quickly. That brings us to severe reactions. Severe reactions to iodinated contrast agents are those that are potentially life-threatening and require immediate treatment. Once again, I want to proceed by saying that these are very rare. It's not every patient that walks into the CT suite that's going to have a severe reaction, but we have to be mindful that severe reactions can occur. Things that are embodied by severe reaction are profound hypotension, laryngeal edema, severe bronchospasm, pulmonary edema, cardiac arrhythmia, seizure, cardiopulmonary arrest, and death. And so if we look at the big things, we have pulmonary edema, cardiac arrhythmia, cardiopulmonary arrest, and death. And so we're dealing with things that can shut the heart down or alter the way that the heart pumps, which allows fluid to back up into the lungs, or we alter the rhythm of the heart, and which ultimately leads to cardiopulmonary death, arrest, and then potentially death if the patient cannot be brought back from cardiopulmonary arrest. So it's important to keep in mind that a severe reaction can be out there. I've really never seen a severe reaction to iodinated contrast. Pretty much patients tolerate it very well. I have seen a mild reaction before, but I've never seen anything go this far. And so this would be something to really keep in mind, that this is out there, because oftentimes we get too complacent thinking that we've never seen a reaction and nothing is ever going to happen about it, but there's still that potential out there for it. And so it goes back to our 4 H's and the heads up portion, to where we need to be mindful that reactions can occur and monitor the patient until there really isn't any danger for the reaction to take place any longer. In a small percentage of patients, delayed reactions can occur. These delayed reactions are urticaria, pruritus, nausea and vomiting, drowsiness, headache, fever, and chills. But notice that this is a very small percentage of patients. And these range from mild symptoms to moderate symptoms to potentially even severe symptoms. So the severe reactions heading here is kind of a misnomer. It kind of encompasses all reactions in the degree of severity. But we have to be mindful that in a small percentage of patients, such a small percentage that you may never encounter somebody who has a delayed reaction, that things can happen after the fact, after they've even left the CT suite. And many times, it's hard to pinpoint this, whether it's an iodinated allergy or not. If the patient has received any type of other medication, it can be pinpointed to potentially this other medication as well. So it becomes not as easy to pinpoint whether this is an iodine-related allergy or not. And so from that point on, the patient needs to be watched and pre-medicated in case that there is a potential iodine allergy. But once again, just like severe reactions are very rare, these delayed reactions are very rare as well. Another thing that becomes attached to severe reactions is this: contrast-induced nephrotoxicity, or CIN as we'll abbreviate it, which is a potentially serious delayed effect of contrast agent administration. It is a considerable decline in renal function that can occur after a patient receives an IV contrast agent. So basically what happens is the patient's renal function probably wasn't good to start with, or it was adequate, but with the administration of contrast medium, the renal function has steadily declined. And it's displayed as a marked increase in serum creatinine levels from a level that was normal before administration. And so you remember how in the first lecture we said that GFR was the best indicator of a person's renal abilities. And this is marked with a serum creatinine level increase. Potentially maybe the GFR wasn't in the highest range that it possibly should be, but the creatinine levels were okay before the scan. So the scan proceeded, and after the scan, the serum creatinine levels start jumping up. It may be related to a renal vasoconstriction and or the toxicity of the contrast medium itself. So we really don't know whether it's related to just the iodinated contrast medium being slightly toxic, or just it shuts the kidneys down due to its toxicity. We really don't know what is causing this, but we do know that the renal function was potentially normal before the scan, and afterwards it's not normal any longer. And some of the risk factors that they've attributed to this are diabetes, myeloma, advanced stage, and cardiovascular disease. And so if you notice, back in our slide that had what things can contribute to an adverse reaction, we had these things as well. We had diabetes, myeloma, and cardiovascular disease. And so there is some degree of commonality between these risk factors that can increase the risk of contrast-induced nephrotoxicity and the risk of even a contrast agent allergic reaction as well. So these are things that we need to be mindful of and watch these patients even perhaps more closely than we would any other patient because of these associated risks. So while contrast-induced nephrotoxicity seems like a very, very bad thing, the good news is that in patients with normal renal functions, the risk for development of contrast-induced nephrotoxicity is extremely low. And so typically your normal patients are not going to develop this. It's those that have those qualifying factors such as diabetes, myeloma, advanced stage, and cardiovascular disease that will have an increased risk for this. However, patients with non-insulin dependent diabetes who are taking an oral bigunide or metformin drug may also have a higher risk of contrast-induced nephrotoxicity. And so that is why we actually have a protocol in place for people who take metformin. So we have patients who have associated risk factors for renal insufficiency and are currently taking a metformin drug are typically instructed not to take the metformin following the contrast study. And this is for a period of 2 days after the administration of contrast. And I realize that every hospital's protocol is a little different. Our protocol was switched by the physicians from 48 hours or 2 days after the scan to 24 hours before the scan and 48 hours afterwards. So you completely eliminate any potential side effects of having metformin in the bloodstream. So I do realize that every hospital's protocol is different, but what we're looking at is what is recommended usually overall by all of the physicians and all of the doctors who study the reactions of contrast mediums. And they recommend that 2 days is sufficient after the administration of contrast to ward off any of the contrast-induced nephrotoxicity.